6 more lab hours.
All right, close enough.
I'm ready.
Let's talk about kidney stones. Who gets kidney stones?
Yeah.
Who gets kidney stones?
My mother has them a lot.
Who gets them more than her mother?
Probably no one. She has to get a lithotripsy, but she's had many of them, but she's got to get
Middle-aged adults.
They have to go up her kidney, do a lithotripsy on one side, and then go with a catheter on the other side. She has to be a few weeks with it.
Like a
Has she changed what she eats?
She eats really healthy.
Yeah, but that doesn't necessarily mean anything. Has anybody ever seen what her stones are made of?
I don't know that. I mean, I know they're like 9 millimeters.
Jeez.
She gets some really bad.
Most people that get kidney stones are men.
And they hurt.
And they hurt.
I've never seen my mom cry like that. My mom's like a healthy woman.
10 babies.
I've heard that's how our closest to men.
Having a baby.
Yeah.
The pain of labor to a man.
That's what they say. I haven't
That's what
had
they
one
say.
yet. Haven't had one yet.
Strictures and renal trauma. We discussed renal trauma at the beginning. Strictures, everybody knows what a stricture is, right?
No. To be honest,
Narrowing of whatever. Could be the urethra, could be your ureters, it could be your renal veins or your renal arteries. Anyway, up to you to read up on those. Kidney stones. Usually kidney stone pain is here. Can go all the way down to the groin and scrotum of men. This is what a kidney stone looks like. Women do get them as well. And like Aaron, I said, that's closest thing men get to labor pains is kidney stones. Seen kidney stones take big men down. They're very, very painful. But generally, they're painful, not necessarily painful when they are like here,
Oh, no.
when they got room to roll around. But when they start going down here and getting to your ureters, that's when you start having the very serious pain. Because you can see there's not really room for it there, is there? So that's what causes the very serious pain. Usually right here, no pain. Down here, serious pain. Then when it gets to the bladder, no pain again. And usually even when they pass them, not necessarily a whole lot of pain. This is where the main time the pain occurs. That's not, saying that they would ever have pain anywhere else, but usually that's when the most severe pain occurs.
It's more discomfort after it gets to the bladder and it comes out. It's a little more discomfort than it is pain.
Okay.
I know.
I believe you. So you can feel it coming out.
Oh yeah.
Okay.
It's pressure.
More like pressure.
Yeah, it's like a garden hose that you kink up and it goes.
I know it. You can hear it in the
I had 10 of them.
tingles.
At once?
No, over a period of time. But it was what I was drinking.
What were you drinking?
Diet Mountain Dew.
Yeah, it's the sugar substitute I've heard causes.
I've not had any since I quit.
Good job. Did you have your stone analyzed to show you what it was?
It's more uric acid. It was
Uric
an
acid.
acid base, yeah. Not calcium.
Usually the good news is people that have kidney stones keep getting them. He had 10. Kidney stones occur more in the summer. Why?
Dehydration.
Because of dehydration. There's many different causes of stones. Several of them are calcium. There are uric acid stones as well. Cystine stones are an amino acid. That might have been what you had, Matt. And then there's struvite stones, which are usually female stones from UTIs. Here you go. Here's your kidney stone guy. Let's see what's on here. Dehydration, immobility because of stagnant urine. Pain, I said that. Alright. They may remove stones with a cystoscope. Okay, I already said that. There's all kinds of treatments they can do for kidney stones. Just a minute. Read my notes, see if there's anything. No, not really.
What do you remove it with? Oh, there it is. I see it.
Yeah, cystoscope. There's also, kidney stones may pass spontaneously. Your job as a nurse, of course, your first intervention for this patient when you get them for kidney stones is going to be what?
Pain.
Give them pain medicine. Give them the good stuff. They're not going to be addicted because they're having pain. Okay? Unless they refuse it. But give them the good. Give them the back shelf stuff, which is what? Dilaudid. Dilaudid is our best friend.
Most of them get Toradol.
Get what?
Toradol.
Toradol. It's
It's
not the good stuff.
But it works.
It does work well on
It
kidney
works
stones
better, yeah.
because it is also has antispasmodic properties. Toradol. Toradol is oh gosh, what's the generic name for Toradol?
Nor,
It's something with a K.
K-E-T-O.
Yeah.
Ketorolac.
Yeah, Ketorolac.
Is that how you said it?
Yeah.
Correct me if I'm wrong. I don't always know how to say these.
You get it all.
You get it after C-section.
Get what?
You get it after C-section.
You get Toradol after or Ketorolac after C-section. And no pain medicine. Not the good stuff.
They try that first before giving any.
Oh, okay. Yeah, I think they would rather dole out the Ketorolac instead of the morphine, but you're going to be given morphine for kidney stones, most likely. You might do the Toradol and morphine. They might alternate them.
I've never had it.
You never had morphine?
Nope.
Just Toradol?
Yep.
Missed out.
No Dilaudid?
Nope.
They must not like you.
I mean, they just,
If it worked, that's all that matters, right?
Right.
And it worked?
I know at work, that's the first line they do is Toradol because of the spat, what is it,
Mm-hmm. Antispasmodic.
and
Okay. I'll believe that.
Flomax or Terrazone?
Flomax or what?
Terrazone?
I don't know what Terrazone.
I guess it helps smooth the urine.
Terrazone
wall.
Flomax.
Yeah.
Yeah.
Is that the same? Okay.
Yeah.
That didn't sound familiar.
It just opens it.
Helps with kidney stones as well?
I guess it smooths your ureter, so it helps pass. You can help pass it easily.
That makes sense. Since we give it to people that can't, for urinary retention.
It says it relaxes the muscle tissue in the prostate in men.
Right. Flomax. Wasn't that one of your drugs for clinicals?
And
Yeah. What else? Those are the drugs I want you to know. I've got them written down in my office. I don't know what they were exactly. But I think it was Flomax or the other generic name for it. I know it wasn't, well, anyway, you can look them up. I'll look them up. I'll send them to you. Okay, so we talked about this already. They can actually analyze what they'll do. Here's what happens if you go to the hospital and have a kidney stone. Generally, they will, you're going to be in pain. They're going to give you pain medicine. Whether it's Ketorolac, whether it's morphine or Dilaudid, whatever, they're going to make sure your pain's controlled. Or you're going to make sure your patient's pain is controlled. No, sorry. You're going to get a strainer, and you're going to teach your patients to strain all their urine. And so if you have a male patient, they will void into their urinal, and then you will pour it through this strainer. It's just like, you know what a strainer is, right? And you can put it in the graduated cylinder. You know what that is, right?
Yes.
The empty urine intake, yeah.
Yes.
Pour it through the strainer, then check for stones. If there's not any, you can dump it out. If there is a stone, you want to save it, give it to or ask the doctor, healthcare provider, if they want it analyzed. Then they'll send it to the lab, and it will come back and let them know what your stones are made of. And then you can plan diet, like Matt said, accordingly, so that you don't keep getting kidney stones, because nobody wants to keep getting kidney stones, I don't think. Make sense? Now, if they're big stones, like your mama, they may have to do other procedures to get rid of them, to break them up, so you can get rid of them. They may do lithotripsy, where they send shock waves in through your back, into your kidney to pulverize those stones. They may do cystoscopy to remove the stones from the bladder if you can't pass them.
My mom would have bruises all over her back from that.
From lithotripsy?
Yeah.
Wow, I didn't know that.
She's a little lady. So.
I did not realize it caused bruising. We talked about cystoscopy. Hang on. They may have to place nephrostomy tubes until your kidneys heal themselves. Nephrostomy tubes are tubes that go into your back, into their renal pelvis to drain urine. They're little. They drain into the separate bags. So you as the nurse, if that's your patient, want to make sure you do not manipulate those nephrostomy tubes unless ordered. They may have an order to flush them. If they do, you want to use sterile technique. You want to use no pressure. You want to go slow. Make sure the patient doesn't catch that nephrostomy tube on the bed rail when they're getting up. You don't want to yank it out because you can really destroy their kidney. Also, nephrostomy tubes have a tendency to leak. So if your patient has nephrostomy tubes, make sure that you've got their bed padded with chucks or some kind of absorbent waterproof pads. If they're going home, if you got their pain under control when they're going home, you'll send them home with a strainer if they haven't passed the stone while they're there with the same instructions. All right, kidney stones, check.
Mm-hmm.
Okay. Other thing I want you to know, remember nephrotic syndrome, right? What do we know about nephrotic syndrome?
Edema.
Swelling. Vascular problems, we're talking about nephrosclerosis, and that's it. These are all in your book for you to review. And what I want you to know about nephrosclerosis causes high blood pressure. So if your patient has nephrosclerosis, you're going to be doing blood pressure interventions. Nephrotic syndrome, swelling. Nephrosclerosis, nephrotic syndrome,
Swelling.
nephrosclerosis.
High blood
All right,
pressure.
that's all I want you to know. You know it now, right?
Mm-hmm.
So these are the people that's going to come in and is going to do serious blood pressure control. IV blood pressure medication. All right. We're going to talk briefly about polycystic kidney disease. All of these are hereditary diseases. So if your patient has any of these, you would want to teach them about genetics and about getting their offspring tested so that they can get interventions early or know what to watch for early. And we are going to talk about polycystic kidney disease. That looks something like this. Terrible, doesn't it? So basically, polycystic kidney disease, your kidney develop cysts all over. You see those bubble blister looking things? You can get this big. And again, this is hereditary. Can be painful. The blisters themselves are not, or the cysts themselves are not going to be painful. But you see how big your kidney's gotten? And you know your kidney's only got this much room, right? All your innards have their place, right?
Right.
They're only allotted so much space. So if this kidney starts getting bigger and bigger, it's going to put pressure on other organs and your nerves. It's going to cause pain, like pain.
Is it true when you get a kidney transplant that they can't take it out? I thought someone said they had to make it like,
Now
you
that
gotta
I
keep
don't
the
know.
kidney
That
in
would be
there.
hard to do. Usually if they do kidney transplant, they do not take the old kidney out.
Yeah.
But considering this one takes up this much room, I don't know if that's true with polycystic or not.
Yeah.
And it would seem like the
I
cyst
know
would
someone
spread
had
to
several
the...
in there because they keep having the
Really?
surgery and
They just kept
then
putting
they
them in?
they didn't know they was gonna have room for the next one, but there was just enough room to do it again, but.
That's pretty different. Anyway, did you have your hand up? Yes.
Did you say that they leave the old kidney in?
Yes. For kidney transplants, usually they leave the old kidney in.
I think it causes like problems. I've never heard that. I never realized that.
No, we'll get back to that.
Pretty interesting.
But I don't know about this because gets so big. And these cysts, I would think the cysts would spread to the new kidney if it was left in there. These cysts can spread to other internal organs. There's usually no early signs. The signs and symptoms appear later due to the pain, hematuria, heavy feeling. I said it may spread to other organs. Usually diagnosed with MRI. These are definitely renal transplant patients. If it's too far gone and if it's affected too many other organs, it's going to be end-stage renal disease patients. They're going to have dialysis and basically palliative care. Okay. Kidney cancer and bladder cancer. Both can be caused by smoking. Also, you're at risk for kidney cancer if you have high blood pressure, obesity, end-stage renal disease. Talk about that. Hematuria, signs and symptoms, hematuria, flank pain, masses, weight loss, metastasis to other parts of your body. Treatment for kidney cancer is going to depend on the stage. So they may just take your kidney out. If it's too far gone, they may just do radiation, chemotherapy. So if you're having this is your patient, they're having their kidney removed. Preoperative. What do we teach patients pre-op anyway? All of them.
Don't eat
Don't eat
after
after
that.
Don't eat after midnight.
No water, food.
Medication.
Make sure to
Maybe.
wash yourself
Stop
with that scrub.
medications.
Maybe. Pre-op. What do we normally teach patients
Take a shower.
about post-op?
About your education.
Teach about
Really do
post-op.
your education, post-op,
Like what?
when they can return to work and movement and.
Risk for infection.
charge plans start on admission, that's just true. Wound care. Pain management, yes, you need to let them know that you will be there to manage their pain after surgery.
Signs, symptoms of infection.
Symptoms of infection. But before they go to surgery, you're going to want to teach them how to turn, cough, and deep breathe.
Oh, yeah.
That you'll be expected to turn, cough, and deep breathe. Range of motion exercises. Pain control is a good one. Where their incision is going to be, what it may look like. Sinus spirometer, they may teach that pre-op. Things to report.
Where report?
What?
Where to report if there's a problem, what to do if there is a
What to
problem.
do. Absolutely. So, lots of teaching goes into pre-op. You're going to teach the patients who are going to get labs at the crack of dawn, and you're going to, because there's a lot of teaching post-op too. The more you can do before, the better off you are. And a lot of times people post-operatively, if they've learned it pre-operatively, before they've had anesthesia, before they've had pain and all that stuff, they're going to remember it better than you try to teach them post-operatively. Does that make sense? So that's what we kind of tell them, teach them all this stuff first. Of course, other teaching would be sign your consent and, if you consent to blood. Post-op, you're going to be vigilant about urinary output, fluid and electrolytes, and you already said pain. Do you remember how you monitor fluids? Eyes and nose, daily weight. How do we do our daily weights?
Morning.
Same clothes.
We wanted to make them naked.
Same time.
Is that you calling from home?
Well, that's what the older lady would tell me. She said, well, I'm this much naked. I'm like, that's great.
0.5 mil. That's how you weigh naked?
Every morning.
Your patients?
No, myself.
In front of your patients?
Well,
If they're watching, whatever. 0.5 milliliters per kilogram per hour. That's your goal for urine output. Usually comes out to be like 50 milliliters an hour. 0.5 milliliters per kilogram per hour. Ooh, that'd be good math questions.
No.
It would
No.
too. Yes, it would.
Say that again.
0.5.
Milliliters.
Can I write it?
Would be able to.
0.5
How nifty.
milliliters per kilogram
I know, I like that.
per hour. That's cool. Huh.
I like that TV.
I do too. Y'all are just like it at home. I stand at home and do this. I practiced it. I don't. None of that's true. That's a joke.
That's what I said.
Oh, another thing to teach pre-op would be how to splint your incision when you cough.
Yes.
Will this go away when I do this? Yay! This is what a laparoscopic nephrectomy looks like. Robot assisted, I think.
Mhm.
I'm not seeing a picture.
Well, that's a lot.
that's what it looked like when I watched it all about.
Was it? Just looks like it was all a bunch of little arms in there. Laparoscopic surgeries are preferred because you don't have such a big incision. Less risk of infection, better chance of leaving early, faster recovery. All right. Bladder cancer. First sign of bladder cancer is usually painless hematuria. Painless bloody urine. Can be caused by smoking, I said, exposure to dyes, analgesic abuse, recurrent kidney stones, chronic UTIs, or indwelling catheters. Signs and symptoms may be, if there is any, painless hematuria, dysuria, frequency, urgency, to be diagnosed with an MRI, IVP, ultrasound, cystoscopy, with a biopsy. Can be treated with intravesical chemotherapy. They can actually take chemotherapy and put it into your bladder through a Foley catheter or through a catheter. They put it into your bladder. They take the catheter out. I don't know why I said that. Bless you. I thought it was a kid in here for a second. Anyway, they retain this chemo into their bladder until then you go back. The nurse would go. You as the nurse would go back and empty it. Sometimes they might want to roll around to make sure that you might have to teach them every 2 hours to move to different spots to make sure that chemo's hitting all the cancer spots. Okay, I'm sorry. May change positions every 15 minutes, so it hits all the spots. Usually, if you have intravesical chemotherapy, you don't have the side effects of chemotherapy that goes into your bloodstream, like loss of air, like all the nausea and vomiting, like sores in your mouth. They may have radiation, immunotherapy. If it's a superficial tumor, like it's on the bottom of the bladder, they may do a TURBT, transurethral resection of the bladder tumor, where they can just go through the urethra into the bladder and use an instrument to cut that out and get rid of it. And post-op care, again, you're going to be watching that urine output. This is for a TURBT, post-op care. Took me a minute to realize. What's going to happen, they may have like a little scar in there where they took that tumor out. And those little scabs may fleck off in a few days. So you want to teach your patients to watch, to not be alarmed if they have little brown or red spots in their urine for 2 or 3 days, or even 3 or 4 days after the surgery. And they may have their bladder removed and urinary diversions placed. This is a urinary diversion. This is a, what is this called? Ileoconduit. Ileoconduit. So they take your ureters, join them into one. They make this from a piece of your ileum, which is part of your bowels, right?
Mm-hmm.
So they create this ileal conduit out of your piece of your bowels. They keep this section of bowel connected to circulation so it doesn't lay there and die. And then they make a stoma on the outside of your abdomen. So remember last week when I told you needed no colostomy care? Urostomy care is going to be just a little bit different. The bags for urostomy are different. They have like a spout at the bottom because it should be liquid that you're draining. The opening is smaller. You want to make sure you know how we cut the flange to go around the stoma. You want to make sure it fits perfectly on these because you don't want that urine laying on the skin because we know urine is very acidic. Because this is part of the bowel, you might have flakes of mucus in it, which is totally normal for this kind of procedure, for the conduit. Urostomy bags, you want to empty them when they're like a third full, because if they get too heavy, same as colostomy, they're going to pull off and start leaking. Big difference between changing this bag and a colostomy bag is you're going to have something to catch the urine, because it's not going to stop long enough for you to change it.
Can you plug the hole?
You can cover the hole, let's say. I think you can really plug it.
Sorry.
You should be able to cover it. I don't know if they just make a plug for it. Then there's also a procedure where they take the ureters and make a bladder substitute. And when this heals, they should be able to void regularly through the rectum. All right. Oops. Okay. Urinary diversions. Check. Urinary incontinence. Stress incontinence is what? Stress urinary incontinence?
It's for your bladder, you sneeze, like
Like when you
When you
Yeah.
sneeze or
Yeah.
cough. Urge incontinence is
You gotta go.
Gotta go.
you don't feel like you have to go to the bathroom, and then you don't have to void. Yeah, by the time you get there, you've already gone.
Yeah.
Overflow incontinence. Have you heard of that?
That's where you wait down until you're already full and then it overflows.
Kinda. Or people that don't feel the urge to go, or have some problems with voiding, and eventually your bladder gets so full it can't hold anymore, and it'll squirt out a little bit again. Reflex means you no longer feel the reflex to void like you learned when you were a kid. And functional has to do with cognitive impairment. Urinary incontinence is diagnosed by urinary incontinence. Sorry. Teaching. What are we going to teach our patient about urinary incontinence? Kegel exercises, absolutely. Lifestyle modification, watch what you're taking in. But make sure you get adequate fluids. Make sure you make yourself go void every 2 to 3 hours. Avoid constipation. Pelvic floor exercises we just talked about. Make sure no matter where you are, you know where the facilities are, how fast you can get there. There are medications as well for incontinence. And there's also surgeries for incontinence. I want to show you one. Oh, wait, I've got cartoons. Common causes of incontinence: delirium infection, atrophic urethritis, okay, can't say it. Pharmaceuticals, psychological, excess output, restricted mobility, or stool impaction. And here's some types. This should remind you of the types of incontinence. Functional, you can't get up to go. Stress, she's had a bunch of kids, so every time she laughs, she pees a little. Overflow, bladder, urinary retention, and there's urge. I'm on my way, and I can't quite make it. Yeah, I might have enough. No, okay, these are just, I know you all don't want to be surgeons, but I'm just going to show you, if y'all ever heard of a bladder tuck or a bladder sling, this is kind of what they do. This is kind of how they do it. They use your pelvic bone and make kind of a sling. We do this for women that have incontinence, usually oftentimes it's due to childbirth. And this is just another view of a different kind of bladder sling surgery. So they basically use different parts of your body to hold that bladder back up in there. All right. They use the vagina and the pelvic bone to hold the bladder up, generally. All right, so urinary retention, as a general rule, as we get older, women pee all the time, and men can't pee at all. That's the big difference. Men can't pee and women pee all the time because women have a bunch of kids or whatever, makes your bladder weaker than it was, and then men have prostates that keep getting bigger as you get older. So, urinary retention oftentimes is due to enlarged prostate. Everybody know where your prostate is?
Mm-hmm.
It goes right around your urethra, doesn't it? So when it starts getting bigger, first thing you're going to notice is decreased urine output. First thing you're going to notice is a decrease in your urinary stream. You know, men that used to go in there and shoot those Cheerios out of the commode are noticing that maybe they're not hitting the Cheerios like they were. They're hitting the front of the commode a little bit. Anyhow.
Between standing 2 feet and 1.
Bidets, those were the days.
Okay, standing 2 feet and having to stand really close. Or the guys that pee up on the wall. You used to pee up way up here on the wall. Now you've got maybe a little bit more closer to the floor.
Well, they might sit down now.
Or might sit
It
down.
might take them a while.
Well, this is true. This is true.
I'm just being to the back.
That's it. That's right. Urinary retention can be an emergency. If the patient comes to you and they can't void and they haven't voided all day and you do a bladder scan on them, or even if they're just having excruciating pain and you palpate their bladder and you can feel it's hard as a rock and full, then you need to catheterize them. That is a medical emergency before that overfull bladder causes problems for that patient. It'd probably just be a straight cath, but empty the bladder, and then try to figure out why it's happening. Other causes of urinary retention: obstructions, deficient strength of bladder muscles, neurologic disorders, diabetes mellitus, overdistension, alcoholism, and drugs. Neurologic disorders, I have that on here. Often urinary retention occurs after lumbar spinal surgery because that's where the nerves are, basically, that innervate your bladder. So if those nerves are damaged, they're not going to feel the need to void. Usually urinary retention is diagnosed with post-voiding residual with either a bladder scan or straight cath. There are medications, the same medication we just talked about with Riley. The Flomax is usually used for retention for people with prostate enlargement. But today we learned it can also be used for people with kidney stones. All right. Let's see more. Oh, okay. Here's some interventions for people that have retention. Talk about that in a minute. So some interventions can be scheduled toileting every 3 to 4 hours, double voiding. Teach your patient, sit on the commode, go ahead and void, then wait a couple minutes and try to go again. Intermittent catheterization. Even intermittent catheterization is not as risky as indwelling catheters. medications. Teach, don't drink a lot of fluids at one time, especially alcohol. Drink small volumes throughout the day. Warm up before voiding. Drink coffee, brew tea. Void in the bathtub of warm water. This is especially for like men with prostate issues. Have them void in the commode, in the bathtub. Also, the Crede method, which I don't have on here, is when you go to pee and then you push on your lower abdomen to try to empty your bladder. That's what the Crede method is. CRUDE. Now we're talking about our prostate now. Prostate problems are no fun. Frequency, urgency, and nocturia. BPH, benign prostatic hypoplasia, is basically an enlarged prostate. To make sure your enlarged prostate is not prostate cancer, they will screen you for a prostatic specific antigen. Here is your prostate gland, and here is your enlarged prostate gland. You see how it goes right around that urethra and can cause problems. And one more guy about a prostate. This is how we assess the prostate with the blood finger. It should feel really smooth, not lumpy like this. Residual urine, weak urine stream, we already talked about that. Urgent urine, you see he's out beside the road peeing. Frequent urine at night, nocturia. Straining to pee, and losing libido. So you see the wife is not happy with the husband. And this is basically the same thing except for added to urine. They are also susceptible to urinary tract infection. They may dribble. You're going to notice the urine stream is weaker. So basically, if somebody has BPH, it's usually a matter of watchful waiting. In other words, they will keep monitoring their labs to see if this BPH is turning into prostate cancer. And these are basically the same things we already talked about, I think. Yeah. Here's your BPH medications. I told you this one was one. Oopsie daisy. And I don't know, I'll have to tell you. But these are medications for BPH, which also assists with urinary retention. Or your patient may have a transurethral resection of the prostate. And basically what they do with this, there's an instrument through the penis, and it kind of, I'd like to call it the rotor-rooter, kind of has blades on the inside of it that whittle away parts of that prostate gland so that the patient can pee. Does that make sense? So basically, you got to remember your prostate has a whole lot of, this is on, I gave you all the page numbers for this in my message I sent y'all last night, right?
Yeah, there's a 10 or 12 things.
Yeah, well, one was about prostate and then another one. So basically, after this is done, they put a big catheter in here. It has, it's attached to a flush, a huge bag of flush, and then a huge urinary drainage bag. And the purpose of it is to flush out any blood or blood clots in the bladder. So you as the nurse would have to monitor that to make sure it's dripping like it's supposed to, and to make sure it's draining like it's supposed to. So you will monitor the urine output. At first, right after surgery, it's probably going to be kind of bloody. So you're going to have the fluid going in pretty quickly. As this heals up some, it should slow down and start turning light red or pink. Once it starts doing that, you can turn the irrigant down some, so you're not emptying bags every 5 minutes. And you just got to kind of monitor for the urine output to decide how fast that drip should be going. Okay. I mean, that's right, but I think I lost y'all somewhere, didn't I? So I'll try to find something else to show you what I'm talking about. When they do come back from surgery, they may have what they call traction applied to the catheter, which means it's, of course it's in the penis, but then when it comes up here, it's taped real tight to their abdomen. The catheter itself is. And what that's doing is holding pressure on the bladder to keep more blood from coming in, as much blood from poured out as possible. Okay, they call that traction. If you have a patient that has that traction, you want to make sure you don't go in there and pull that tape off and remove the traction, because there's a reason for it. It's stopping this patient from bleeding too much. They may go home with a catheter as well. Make sure you keep the urinary meatus clean, soap and water. They also might have bladder spasms, which are kind of painful. We usually use B&O belladonna and opium suppositories help with those. I thought I moved this slide, but I guess I didn't. This really went back to the incontinence slides. Some men may opt to put a penile clamp on for incontinence. I've seen a lot of people with these. So they just take the clamp off when they need to pee, put it back on, so they're not dribbling all over the place all the time. That went back to the incontinence, sorry. Okay, now on back to TERP. And here you can see maybe more what I'm talking about. This is what's going in to the bladder, and then this is what's coming out of the bladder, okay? So this you can see, you should set this drip rate to match, to make this, soon as possible, yellow urine. That's going to probably be at least a day. But no clots is what you want them to go for. All right. Okay, real quick, I want to talk about catheterizations. Renal's on 215. I got you before, right?
Mm-hmm.
We don't do catheters just because we're tired of doing incontinence care. All right? Catheters, urinary catheters are a huge risk for infections in the bladder. So we want to make sure we get them out as soon as possible. You should keep the system. This is like I said, nursing school is comprehensive, so a lot of this is back probably from your 101 stuff, but I think it's in this chapter as well. You want to keep a closed system for your catheter. You don't want to take it apart if you can help it. You want to not just routinely change catheters, but you do want to routinely do peri-care at least twice a day for somebody with a catheter. What do you wash them with?
Soap and water.
Soap and water.
Soap and water, right? Not alcohol, because it will burn somebody's hoochie off. You shouldn't use lotions or powders on the perineal area of someone with a catheter. Irrigate only for clots. Sometimes with the CBI that I was just talking about related to the TERP, Oftentimes they will clot off and you will have to use a syringe to irrigate. We talked about leg bag. You said you knew it. Okay, pictures. Picture time. This is a 3-way catheter for CBI or whatever. One of these tubes will drain the urine out, and one of these tubes, the irrigation goes in. Usually this balloon is like the catheters themselves are like 30 French catheters. You know what you have in your kit was what, a 14? So you can imagine they're like this big around. This usually holds 30 or more milliliters of saline. You know to check this when you're emptying a balloon, because it should say how many milliliters of saline are in the balloon. There's this kind of cath. This is a straight cath. These are actually all straight catheters. This is a red rubber catheter. These are stiffer self-caths. If you're using a self-catheter on a patient, straight cath on a patient, I recommend using the red rubber, because they're flexible. These are really kind of stiff and they kind of painful on your patients. This is a Coude catheter. Have you heard of this? Mm-hmm. We use these on men with big prostates. So you would have to attach the bag to this. But this curves up, and when you put it in, it goes right around that prostate and goes in easily. Now, this is for you girls. I have an assignment for you girls. When you leave here, we'll go home, get your mirror out and have you a little look to see what's going on down there if you haven't done it before. Because if you're starting a catheter or putting a catheter into somebody else, it would be good if you knew. Could a person put a catheter in you? You know, we have those mannequins across the hall that have all this perfect in there, right? Simple as pie to put a catheter in it. Well, let me tell you something. It doesn't work that way with a real person. The urethra could be inside the vagina. The clitoris sometimes looks like a urethra. You want to make sure you spread the labia. Like this is what I've seen students do this over there in the lab, and therefore they try to do it when they get to clinicals, and it just doesn't work that way. You've got to spread. There's lots of stuff there to get around, right? Just telling you, get your mirror out. Have a look. You see there's lots of stuff down there. Another picture. Again, see all the layers you have to go through. Make sure you got to spread it. The urethra is not really easy to find on a person with perfect anatomy, because you've got to get in there. And I'll tell you something else. It's not all that comfortable for the person you're doing it to. So please be careful. Try to be kind and gentle. You may have to even go sideways. So there's your mirror. There's your assignment. Get your mirror out when you go home. Not here. And as I told one class before, it brings a whole new meaning to the word selfie. So if you're in a selfie, I do not want pictures, okay? You do not get extra credit for pictures, and I do not want to see them. So anyway, one of my boys made me this. trying to self-cath like he's got his cell phone out, standing on his head, and on her head, I guess.
That is hilarious.
Okay.
All right, guys, it's your
Uh-oh.
turn.
Hey, listen, it's pretty obvious. Now, occasionally,
You and your penis.
I better not.
Yeah, me too. Foreskin, circumcised and uncircumcised. Circumcised and uncircumcised. This is in case you thought you knew the difference. This is what they look like. See this skin here? It's covering this. This is in there. It's just hidden out. It's like a turtle. Uncircumcised, circumcised. And one more time. Uncircumcised, circumcised. Now, what I was going to say to Matt's comment, yeah, it's pretty obvious. It should be pretty obvious where the hole is on a man, unless it's hiding underneath all that. Get back to that. And there are some people that have retracted penises.
You have to push on their belly to pop it out.
You have to push on the belly or push on both sides
Oh,
to
wow.
pop it out. You will. You'll figure it out.
Sometimes it don't work when you have the.
You just gotta
It normally
concentrate.
works though.
This depends on how.
Well, yeah, it takes some people. You can't do it. You don't have that many hands.
I can't wait for the next
I
slide.
know, it's great.
So, one time I told students and said, well, for this patient, probably when you go in, you're going to have to push on their stomach and to access their penis. It'll come out. And then looked at me and said, and so after we went in and did the catheter and came back out, they were like, how'd you know that? I said, not my first penis. There you go. I was asked to describe what an uncircumcised penis looks like without showing one. ET circumcised and ET not circumcised. Something to think about next time you watch ET. Now, some people will develop phimosis. This is called phimosis. You see, this is, so basically if you don't retract the foreskin at least once a day, usually more than once a day to wash, and that sort of thing, this foreskin will just kind of onto the ends of the penis. See how it, well, it's just, it won't retract anymore. That's called phimosis. Now, if you've ever had a patient with phimosis and tried to put a catheter in them, that's quite a challenge because this looks like the urethra there. Normally, you can't see the urethra. All you see is.
Can you drill a new hole?
You can't drill a hole.
No, you just push it in there and hope you make it.
You just push it and hope you make it, and oftentimes you miss, and then your catheter is going around and around, squiggling around in that foreskin, and it's.
What about one of those condom caps?
You could use a condom cap. It's a bad day for everybody concerned. So phimosis is the catheter, the foreskin has shrunk up to the end of the penis. Paraphimosis. Now this is why when we were teaching y'all catheters that we are so adamant about you retracting the foreskin and putting it back where it belongs. This is a patient who's had his foreskin retracted and nobody put it back where it belonged. So what happens here is this foreskin swells up, becomes inflamed, and can also cut off the circulation to the glans penis. And they can,
And it dies.
and it can die. They can lose it. So this is really bad. This can be fixed with a circumcision.
Yeah. So that's the only way it can be fixed is with Circumcising it?
The phimosis?
Yeah. I mean, it doesn't.
Yeah, basically.
Oh, okay.
Because it's too tight, it's not going to retract anymore.
Oh,
So it's
okay,
going to
so
stay.
it's like, okay.
It's like,
Like turtleneck your head and stuff.
you can that won't stretch.
I can't see a guy letting that happen. Unless he
Well,
could-
it happens a lot.
Unless he could.
Couldn't, right, maybe he couldn't access his own penis or wasn't, wasn't taught.
So I had a.
All right, suprapubic catheters are placed into the bladder through the abdomen and are drained. And they just drain like that. They do not get infected as much as regular catheters because there's not as much risk of exposure to stool. There you go. That's what it looks like. Nephrostomy tubes, I've already talked about these, didn't I?
Yeah.
Know that they're going into your renal pelvises.
No.
Yes, yes.
Intermittent catheterization is like straight cast. Oh my. Did you listen? We're ready for did you listen? Patient has a urinary catheter in place and connected to a drainage bag when transferring the patient to another department. In which position should the nurse keep the drainage bag?
D. Yes.
Got to be below the bladder. We don't want urine refluxing into the bladder. The nurse is providing care for a patient who had a cystoscopy 6 hours ago. The patient is voiding 10 milliliters of urine every 2 hours. What assessment will the nurse perform to check for overflow incontinence?
B.
D.
B. No. B.
B.
You would check the bladder scan. The nurse is teaching a group of young women regarding prevention of urinary tract infections. What information does the nurse include?
D.
Yes. D.
D. A 30-year-old male patient had a urinary catheter removed 4 hours ago. The patient is unable to ambulate to the bathroom. Which of the following nursing interventions would be most effective to promote urination in this patient?
A.
Not C.
C is an intervention for people that can't pee.
You could turn the urine on, the water on.
Not turning the water on. Yeah, we didn't even talk
Yeah,
about
that's
that.
what I'm
Warm water over your patient's genitals is a nursing intervention if they're not able to pee.
Over the genitals?
Y'all didn't.
I thought you meant just listen to water running. I thought.
No.
Listening to water running as well. If you're in the bathroom with the patient or their room,
Just turn the
the
running
water on sometimes helps.
Yeah.
The physician has written an order to discontinue an indwelling catheter on a female patient. What would be an essential part of nursing documentation?
B.
Yep.
Yeah.
B.
Well,
It says A.
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 Time and amount of patient's next voided urine. Take 5 if you need it. I'm going to switch slides because we've still got a renal failure. Yeah. What? Who's calling? Megan, is it you?
I don't think so. She didn't say anything.
Am I hearing things? Did you not hear anybody talking?
I don't know.
I don't think so.
Maybe. I don't know who they were talking to. Well, we have another one.
I'm cold.
What would she do? Very important.
It is freezing in here.
Won't be on the test. All right, let's go.
Be sure to post them on the
Now, let me read that to you. The client with acute renal failure has a serum potassium level of 6. The nurse will plan which of the following as a priority action. Finally, you know, if they have high potassium, you put them on a monitor, right? If you have low potassium, you put them on a monitor, right?
Either way.
Okay.
The client being hemodialyzed suddenly becomes short of breath, complains of chest pain, they're tachycardic, pale, and anxious. The nurse suspects an air embolism. What are you going to do?
Oh, you're gonna definitely.
Yes, 1.
Stop what you're doing, right?
Yes.
Yes. A nurse is assessing the patency of a client's left arm AV fistula prior to initiating hemodialysis. Which finding indicates that the fistula is patent?
1.
Yes,
Gotta
1.
feel the thrill.
I mean.
You do.
No, he's right. You do
You do.
feel the
Feel the
thrill.
thrill.
Okay, I
You
didn't
listen
know
to
that.
the bruit and you feel the thrill. Thrill. Feel the thrill.
Okay.
What's it feel like? What's the thrill feel like?
Almost like vibration.
Feel
Like a
it
vibration.
vibrating.
Yeah. What's a bruit sound like?
Swoosh.
Swoosh. Whoever says swoosh is right. Swoosh. 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 It correlates with the heartbeat. Swoosh. 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 The client newly diagnosed with chronic renal failure recently has begun hemodialysis. Knowing that the client is at risk for disequilibrium syndrome, the nurse assesses the client during dialysis for what? Disequilibrium syndrome is caused by rapid removal of solutes from the body during hemodialysis. At the same time, the blood-brain barrier interferes with the efficient removal of waste from brain tissue. As a result, water goes into cerebral cells because of the osmotic gradient, causing increased intracranial pressure and onset of symptoms, which are what?
4.
Yes. The hemodialysis client with a left arm fistula is at risk for arterial steal syndrome. The nurse assesses this client for which of the following manifestations? Ever heard of steal syndrome?
Mm-mm.
Have you ever heard of a dialysis catheter?
Mm-hmm.
If they're in the arm, steal syndrome happens when it's not either they had decreased circulation before or didn't have enough circulation to support the AV fistula in their arm. Therefore, the fistula itself is stealing the circulation from their hand. So Steele syndrome, they're not going to get circulation to their hand because of this fistula.
So diminished pulse? Two.
So it's 2. Very good. The nurse is reviewing a client's record and notes that the physician has documented that the client has a renal disorder. On review of the lab results, the nurse would most likely expect to note which of the following.
2.
Elevated creatinine and elevated BUN. What are creatinine and BUN?
Blood, urea.
Now, what are they?
Electrolytes.
It is kidney function, monitors kidney function, but what is BUN and creatinine?
Or like ketone plant values?
It's basically waste products.
It's your filtration.
It's waste products. BUN and creatinine is waste products. Think of BUN and creatinine as garbage. If you have a whole lot of garbage floating around in your system, you're going to have a high BUN and creatinine. And why would you have a whole lot of garbage in your system? Because the guys that are supposed to be getting rid of the garbage, kidneys, aren't doing their job. That make sense? The nurse is caring for a patient with chronic kidney disease. The laboratory results indicate hypocalcemia and hyperphosphatemia. When assessing the patient, the nurse should be alert for which symptoms?
1, 2, 5. 1, 2, 5.
It's 1. Trousseau's.
One.
How does Trousseau's look? Do Trousseau's for me.
That's like the brush on the face.
Oh,
Or
it's-
oh. The arm.
Trousseau's for
Oh,
me.
the other one's cheddar.
Straw sticks for me.
Yeah.
Mm-hmm.
Go
Chopsticks.
almost fight.
I can't
And
do that.
backwards.
You can't wrinkle up your face.
I can't make my-
Trousseau's, cardiac arrhythmias, and fractures.
Okay.
Because if you have a lot of calcium in your blood, where
that
do you
makes
not have
sense.
enough calcium?
In your bones.
So you're going to put one of those on the test? Maybe?
That is the test. Y'all passed. All right. Kidney failure. There's acute kidney injury and there's chronic kidney disease, and I've just kind of combined them both a little bit. A lot of the signs and symptoms and the interventions are the same, but you need to know there is such a thing as acute kidney injury and chronic kidney failure or chronic kidney disease. Sometimes one can lead to the other. However, acute kidney injury, we as nurses can prevent, and with early assessment, we can get it fixed pretty quickly. Might be days or months, but pretty quickly. Okay? Acute kidney injury, we can fix it. The nurses should be vigilant enough to prevent it, know when this patient's starting to go into acute kidney injury, and help reverse it. All right? So acute kidney injury is rapid, happens pretty quickly. Chronic takes a long time. Acute kidney injury can go to chronic renal failure, but if we can fix it, we will fix it. We've talked about already, way back hours ago, about all the things your kidneys do. If you're in kidney failure, that's not happening. You're going to be anemic because your kidneys, the erythropoietin is going to be gone. You're going to be full of garbage because it's not being filtered out. Your blood pressure is going to be wacky because your kidneys aren't helping control it. Your blood pressure is going to be high because you're going to be full of fluids. Your electrolytes are going to be weirded out. oftentimes happens with people that are already in the hospital. We kill their kidneys. How would we kill their kidneys? Not kill them, but you know what I mean. How could we cause kidney failure? You as a nurse, like what?
Too much fluid.
NSAIDs, somebody said. What else is nephrotoxic? Y'all said it a minute ago. Antibiotics. So if we're given a nephrotoxic antibiotic, we want to make sure we're assessing renal function, right? Because we're good nurses. We're the best. So just because it's ordered doesn't mean you do it without question. Because you're the nurses, you've got to know if those antibiotics are appropriate. You can question pharmacy and you can question the doctor. Okay? Don't be scared. Don't be scared to be a patient advocate. So you have to know. You need to know the first signs of kidney failure so you can notify the doctor, especially if it's somebody on nephrotoxic medications. Okay. Let's go over here for you. This is what I want you to know. I mean, I want you to know all this, but I want you to know about these different causes. Acute kidney injury can be caused by, usually it's caused by hypertension, hypovolemia, or nephrotoxic agents like antibiotics. So we need to prevent it. So pre-renal, those pre-renal, intra-renal, and post-renal causes of kidney injury. Pre-renal would be, for instance, something that keeps them from having enough blood flow to their kidneys, to perfuse their kidneys. Okay? Like, can you think of any instance that would be, can you think of an instance that would decrease the blood flow to the kidneys?
Blockage.
Some kind of blockage, blood clot?
Vasoconstriction.
I didn't hear you.
Vasoconstriction.
Vasoconstriction, trauma, aneurysms. So that's pre-renal. So, like I said, if we fix that, fix the cause of the trauma, then we can restore their kidney to normal function. What about intrarenal?
Like, taking NSAIDs, different drugs that mess up your kidneys.
Yes, yes. If intrarenal is due to something that's going on that caused direct
Chemicals.
problems to the kidney. Can be chemicals, could be prolonged ischemia, the blood flow affecting, not getting enough blood flow to the kidney could kill the kidney. I didn't know what you said. Dehydration, blood transfusions, crush injuries like car wrecks from using your seatbelt. So intrarenal is something that's going on right inside the kidney. Could be glomerulonephritis. Or post-renal. What can you think of a post-renal cause of renal failure?
Cancer.
Cancer of
The
bladder, maybe?
yeah, bladder.
Prostate,
Oh, yes,
Tumors.
that's right there.
stones.
Stones, enlarged prostate.
Injuries.
Good. Good.
Diabetes.
Good. So you got that. Here's more. So that's acute kidney injury in a nutshell. Chronic kidney disease takes a lot longer, generally, and it's where your kidneys are basically not functioning anymore. We certainly need our kidneys, so people with chronic kidney disease are dependent upon dialysis to get rid of the waste products. There's different phases. I'm trying to decide what I want you to know. What stage you're in is going to be based upon your GFR, glomerular filtration rate. So that's what you're going to monitor in your patients to see if their renal failure is getting better or worse. All right, there we go. Causes that can contribute to renal failure are on here. Here is your schematic of a patient with renal failure. You see where she starts out, her GFR is pretty good. And then she starts having renal insufficiency. Her GFR decreases from 90 to 30. 30. I'm getting a little tired. And then she ends up stuck to dialysis. So this is what somebody with end-stage renal failure normally will look like. They have weakness, fatigue, maybe confusion, problems with the cardiovascular system because kidneys aren't working like they're supposed to. Same with pulmonary. You can think of signs and symptoms of fluid overload. GI, their breath then might smell like pee, urine. Usually they're going to become withdrawn, like a lot of people with terminal illnesses do. Anemic. Their skin's going to be really dry and flaky. It might have uremic frost, which is where they have uric crystals form on their skin because their kidneys aren't doing what they're supposed to. Remember, if somebody has a dialysis catheter, you do not want to squeeze it. So you don't want to put a blood pressure cuff over top of it. Generally, if somebody has renal failure and they have an AV fistula, they will have, depending on, if they're brand new renal failure patient, they might have this one. If they've been a renal failure patient on dialysis for years, they're going to have this one, they're going to have an old one up here, an old one here, and because they don't stay good forever. So anybody that has an AV fistula, you want to teach them how to take care of it. This is totally implanted in their arm. They should not wear tight clothes over top of it. They should not sleep on top of it. You want to teach them to baby that as much as possible. And hopefully they would tell you when you walk in the room to check their blood pressure, they're going to say here, if their site's in this side, they're going to hold out this arm.
Well, they usually have a bracelet on.
They usually have a bracelet on. Sign over top of the bed. We used to do that as well. Diagnostic studies. Here's what I want you to know. How are we going to take care of these things? Painful. It's patients and people together.
Do you want to know the normal lab values for the GFR? Like, is it going to say like 90 and we're supposed to know that's normal?
No. I'm more interested in knowing this. This is nursing. So this is the assessment. Usually when they first start into renal failure, they're going to have polyuria, which is a lot of urine. This is chronic, because it's the opposite with acute, but I don't care if you distinguish those. So this is chronic renal failure. They're going to have a lot of urine at first because their kidneys can't filter it well. And then they end up with oliguria and then anuria, which means there's a lot of people that are on dialysis don't void it all. So if they're not voiding, there's going to be waste products accumulating. So for us as nurses, here's what we're going to do in relation to those things right there. You're going to monitor their fluid status. You're going to do daily weights. Same scale, same bedding. Remember this, 1 kilogram equals 1,000 milliliters of fluid. Does that sound familiar?
Yeah.
Strict eyes and nose. Monitor edema. And what are edema interventions?
Elevate the line.
What?
Like elevate the edema. So, yeah.
Withhold fluid.
Yeah. STDs.
Low sodium.
And who?
Low sodium.
Head up.
Head up.
It says lung sounds. You want to make sure they're not developing crackles in their lungs. They have fluid overload in their lungs. Monitor skin turgor. Mucous membranes. What do you think the mucous membranes are going to be like? Blood
Dry.
pressures and pulses. And so we're monitoring fluid status. This is all stuff you know, right?
Yes.
Then you're going to monitor fluid intake. Here's you another math question. Your fluid restriction for tomorrow will be everything you have out today plus 600 for insensible. For those well, you had that insensible loss, the puff of air. All right? Everything you have out today plus 600 will be how much you are allowed to have tomorrow. Okay? So if you have 300 urine, 250 emesis, 200 of diarrhea, that equals 450, 1350. Oh, plus 600.
Oh.
1350 for tomorrow, and then generally we divide it between 3 meals. So 1350, and then you'll have like some extra for medications or snacks. All right. So since they're on fluid restrictions, nurses are going to measure all I know, give them hard candy, sugar-free most likely, because diabetes is one of the #1 causes of renal failure. Everybody knows that, right?
What, diabetes?
Yes.
Yes.
Mouth swabs, chewing gum. I told y'all before, it's one of the hardest things to do for a nurse, I think, is fluid restriction, because they just beg for water. The patients will. I had a patient that she had a headache every 4 hours because she wanted that Tylenol so she could have that little sip of water. It's sad. I think it's sad. Okay, they're also going to be in an altered carbohydrate metabolism. When they're in renal failure, diabetics may require less insulin because the insulin is not being eliminated either. They're going to have elevated triglycerides. So, nursing interventions, blood sugar checks. Usually, when do we do blood sugar checks?
Before meals.
Before meals and at bedtime, right?
Yeah.
And sliding scale coverage that they're usually be on. Interventions for elevated triglycerides, low cholesterol diets, and statins. That's a pill that helps with your cholesterol. Hyperkalemia. The patient might be have hyperkalemia because they're not getting rid of the potassium. They might have too much magnesium. Usually that's not an issue with renal failure patients unless they're taking a lot of milk and magnesia. Oh, you think about your mom? If it gets bad and the potassium's so bad that it's causing problems with your heart, they're probably going to take you to dialysis. These patients are going to go to dialysis eventually unless we can fix them. So, for hyperkalemia, you want to teach them about diet changes. What kind of diet, what kind of things should they not eat if they have too much potassium already?
Salt substitute.
Salt substitute for sure. Bananas. Anybody else remember high potassium?
Dried apricot, or apricot.
Apricots, do they have a lot of potassium?
What is spinach, green leafy vegetables?
Potatoes, cantaloupe,
Even chocolate.
chocolate. Of course, you're going to put them on cardiac monitor if they have too much potassium. You're going to give them glucose and insulin or IV calcium gluconate. What those both do is push the potassium back into the cells. K-exolate, do you know what K-exolate does? It binds to the potassium and causes your patients to poop it out.
Oh, okay. What did you say that did?
It binds to potassium and is removed through the stool. What I meant to say. And like I said, prepare for dialysis. The sodium may be normal or may be low. So you generally, patients with renal failure, chronic renal failure, have sodium restrictions to 2 grams daily. Some of y'all did some
2
low
grams
sodium diets, didn't you? Did anybody do a low sodium diet? No, was that not one on the list?
I did one for Amish.
Low sodium?
Yeah. Yeah.
Yeah, I knew somebody did. Maybe it was just you. Hardly, but they just don't remember.
Yeah, I did for Amish, yeah.
So you should be an expert in telling them what to eat or not to eat.
Fine, I can do it. If you're an Amish, you want to curd, strudel pie.
Metabolic acidosis, because kidneys are unable to excrete acids. Monitor for Kussmaul's respirations. Try to fix the underlying cause of the acidosis, which is what we always do for acidosis. Your patient is going to be anemic because of the erythropoietin, which is a fun word to say, because of not enough nutrition, because of all these kinds of things. They don't have enough iron, which is not a fun word to say. Nursing interventions, erythropoietin is given in Epigen or Procrit injections. You heard of those? They may also get iron supplements, ferrous sulfate. Don't give them blood unless they absolutely have to, because if you give them blood transfusions, it tells their kidneys they don't need it to generate any more erythropoiesis to get more red blood cells from the bone marrow. Also take a chance of iron overload. Hematologic system. They're going to have bleeding tendencies. They're at risk for infection. You're going to institute bleeding precautions, pressure to any injections, monitor stools for occult blood, assist with ambulation. You're going to try not to give medications IM. What else can you do for bleeding precautions? I know, not straight razors, but electric razors.
Right.
What else can you do? You might know anything that you do know. You've shut down on me. You sleeping?
Restrict Coumadin.
Monitor for bruising, things that indicate that they're bleeding. Okay, anyway, infection precautions, limit visitors, use the septic technique, monitor for signs and symptoms of infection, use good hand washing, always administer antibiotics. Of course, you always want to monitor those antibiotics to make sure they're not nephrotoxic. We don't want to We don't want to make things worse by trying to make things better. Cardiovascular, they may have hypertension, dysrhythmias, there's medications, diet changes.
What's DASH mean?
DASH diet, it's a
The diabetic diet.
DASH diet is for blood pressure. Yeah,
Oh, yeah.
it's for people that have high blood pressure. It's like, yeah, I don't remember what the letters stand for, but it's about blood pressure.
Okay.
I don't remember what the letters stand for. Does anybody know?
Google does.
Google mine.
Dietary.
I know the brat.
Stop hypertension.
Dietary approaches to stop hypertension. Just make that up, or it was good. I was about to be impressed. Yeah. So that's for high blood pressure.
Okay.
Good.
Mrs. Dash.
Mrs. Dash. Well, it's probably where Mrs. Dash got her name, or maybe the other way
It's low
around.
sodium. I mean, it's
Yeah, that Mrs. Dash hasn't had any sold it. Okay, respiratory system. All these things can be going on. You want to, as the nurse, make sure that they've got the proper amount of oxygen on. Teach them incentive spirometer. Incentive spirometer should be done 10 times hourly while awake. Oh, buggers.
Oh, wait, yeah.
I'm trying to circle that.
I can't do
It's not
it.
working.
They got it.
I can't do it asleep, huh?
Change positions every 2 hours at least. Ambulate in the hallway 20 feet every 4 hours. Remove fluids, which can be done with paracentesis,
No.
antibiotics.
You mean you don't wake him up? I say you can't do it when they're asleep.
Wake them up.
Okay.
GI system. Urea is being broken down into ammonia, can cause mucous membranes to be inflamed and painful. That's what stomatitis means, sores in your mouth. Might have a metallic taste in their mouth. Urine smell on the breath, I already said that. Weight loss. Frequent oral care, especially before meals, and monitor for signs and symptoms of bleeding. Now, if you're doing oral care before meals, you should not use mouthwash with alcohol, right? Something mild for oral care, even if it's just the swabs, the glycerin swabs. Or saline rinses. Or they make special mouthwashes called magic mouthwash that you swish and either spit or swallow that are good for your stomatitis. When your kidney failure gets bad enough that it's causing neurological deficits, then that's when you're for sure going to be a dialysis patient. Okay? Do you remember what asterixis is? Yeah? Show me. Show me.
Oh, yeah.
No, their arms out, their hands flat,
Oh,
and it's
flat.
because of
Okay, so
liver
it's
failure.
Flappers, just flapping tremors.
Yeah, asterixis.
Yeah.
It's also liver failure because that goes to your brain. What's it
Oh.
called? Do you remember what it's called?
Yeah.
Yeah, encephalopathy. Good job. That's good. When you look at your patient, they're going to be yellow-gray because they're retaining urinary pigments. They're going to be pale because they're anemic. They're going to have dry, scaly skin. Their hair is going to be brittle. It's going to fall out. Their nails are thin and brittle. They itch. Most patients that have chronic renal failure, they have that thin skin and then they scratch. So you can usually see scratch marks all up and down their arm because they itch. I told you about uremic frost, where you might actually see crystals on their skin. Your body's trying.
Lotion helped that.
Your body's trying.
Petechiae.
bruising. You know what petechiae are?
Mm-hmm.
Those little red spots. Ecchymosis.
They go, yeah, red spot.
Joe will always be known as Petechiae. Because he taught that one time he was up here teaching. He kept talking about Petechiae. You know what Petechiae is? These little red spots. And we were like, I think it's finally corrected me. We all make mistakes. So, skincare. Y'all didn't have Joe. Mr. Allen.
Little bit.
For like 3 weeks.
For like, yeah.
Clinicals.
Yeah.
I mean, what's
No, he taught like one thing in here.
That's right. That's right. He taught a lot of psych. Okay. I miss him terribly. So interventions, lotions, antihistamines, meaning like Benadryl to keep from itching. Make sure you careful handle your patients. Sexuality, reproductive system. Patients with issues with decreased libido or decreased sexual drive, you might want to tell them after dialysis starts, it may return. Or if they have a kidney transplant, it should return to their normal functioning. Always be therapeutic when you're talking to your patients. Same here with psychological. I mean, it's basically a terminal illness. So, you know, you've got to let your patients talk, let your patients be involved in their care. I said that already. Monitor every drug you're given. Oh, nutritional therapy. This is when you have your patients in a chronic renal failure, they're going to be on basically a renal diet, which usually consists of protein restriction, measured this way, calories from carbs, measured this way. Sodium and potassium are going to be based on their labs, but usually potassium is only 2 to 4 grams a day. Phosphate restriction, no high phosphate foods. Now let's talk about dialysis. There's 2 different kinds. There's peritoneal dialysis and then there's hemodialysis. So peritoneal dialysis is when they put a catheter into your abdominal cavity and they use that viscera as a screen, as a membrane to remove the waste that your kidneys would remove if they were functioning. So they put the fluid in to your peritoneal cavity, let it dwell, and then they pour it out into a bag. It's connected by a Tinkoff catheter, and it runs off into the bag, and then you start all over, okay? Looks like this. This is a manual exchange. Another big bag of fluid. You warm this up. You attach it here. Goes into the abdominal cavity. It dwells, and then you open this back up. You clamp this, open this back up, and it comes out into the waste product bag. This should be clear when it comes out of the patient's abdominal cavity, peritoneal cavity. If it's not clear, that indicate this patient here. Back up a little bit. Huge risk for peritonitis. Remember we talked about peritonitis before?
Mm-hmm.
Yeah.
Inflammation of the peritoneal
Inflammation
space.
of your gut that can kill you if you don't fix it. So peritonitis can occur with peritoneal dialysis. That's why you want to make sure, if this is you doing these connections for this patient, you want to have strict sterile technique. You want to monitor this fluid that's coming out. If it's cloudy in the least, you need to call the doctor, healthcare provider, and get orders. Usually they're going to give you antibiotic orders. Antibiotics will go in through their IV or into this catheter itself. If this patient, I'll just use this guy again. If this patient has problems with, okay, so you put this in, and as you're draining, only 3/4 of it comes out, let's say. Because you want it, the goal is what goes in, comes out. And it brings all the waste products with us. But the waste products do not have a color. Students used to get confused on that and said, well, it's got potassium in it, it should not be clear. Yeah, it's clear. Those don't have a color. If all this doesn't come out in here, you might want to move your patient side to side, have them reposition before you panic and call the healthcare provider. Reposition your patient, check this, make sure there's no kinks in your tubing, move them, have them sit up, stand up, go turn over on the other side. See, that's really a good SATA question, isn't it?
No. Yeah.
Don't say no.
It is.
Hate 'em too.
So here's our guy. There's his bag going in, and then they clamp it, and then it comes back out. Let's say everything I wanted to say there. Yes.
How long does that process take, or is there a certain time?
It usually
30 minutes?
20 to 30 minutes, but it can be up to 8 hours. It is to be dependent on labs. So some people can put it in and unclamp, go about their business, and not have to come in and drain for 8 hours. But some people, depending on their status, will drain and then immediately start back open. It does give you a little bit more freedom, so you can get out and do things if you can clamp your catheter long enough. They also have automated peritoneal dialysis cyclers that look something like this. And this warms the dialysate for you, and it kind of just goes all night while you sleep. I think I've already said all this, so I did. I didn't say this. They can develop pulmonary complications because if you can imagine having a belly full of fluid, it's not as easy taking big deep breaths as it is if you don't, right? Good Lord, I didn't know I had this one. I want to go to hemodialysis. Hemodialysis is blood for blood. You put your blood, take your blood out, put your blood back in dialysis. This is what we talked about a minute ago, internal grafts. The best patency rate for these grafts are, have I lost you?
Yes, I know.
No? Are we good? Mm-hmm. Okay, I thought maybe I would switch chapters because I do this. So they're connecting an artery to a vein, and then it's implanted under their skin. That's when you get the bruising and the thrill, because the blood from the vein is rushing through the artery. So the needle pulls the blood into the hemodialysis machine. One needle pulls it out, another needle replaces it to the patient. Returns it to the patient, that's the word. I told you about Brill 30, blah, blah, blah. We talked about that. Watch for these complications, and we talked about Steele syndrome, which would be distal ischemia. This is a Tessio catheter. These are temporary. If if you have somebody with acute kidney injury, you might have one of these, because hopefully dialysis wouldn't be permanent for them. So what does the dialyzer do? I already kind of said, so if you don't want to know all this, it's okay. That it takes the blood out, removes all the impurities from the blood, then it gives it back to you. Generally, as it gives it back to you, it warms it up some. So it's not uncommon for patients coming back from hemodialysis to have not high fever, but a low-grade fever, just because they've got warmer blood in them than most people. And you're connected to a machine. They're always going to check your weight before you start dialysis, so they know after you're finished with dialysis how much fluids they've removed. So you as the nurse, you're going to monitor their vital signs every 15 minutes. Nope, sorry, every 30 to 60 minutes. Usually patients at the dialysis centers are in recliner chairs. And they're in recliner chairs because when their blood pressure bottoms out, which happens frequently, we can stand them on their head, put their feet up over top of their heart, which usually restores the blood pressure. There's new trends for dialysis. There's a whole lot of people on dialysis. And I thought it would be kind of like a party. I know I'm stupid, but I asked somebody about that. So I figured everybody know each other, and when it went to dialysis, it'd be kind of almost like fun. But they were like, no, these people are sick. They don't care who else is there. It's not fun. Just saying. But then I saw something on Facebook this weekend too. Somebody had posted a little story, whatever.
They usually have like a TV and they get snacks.
Yeah.
So,
It wasn't a meme though. It was like an article that talked about the empty chair. Talked about people going, that nurses go to dialysis and they see the same people all the time. It's almost like a family. And then they go and there's the empty chair, so they know somebody's gone on. I don't know. Look it up on Facebook. It was good. So here's what it looks like. In the dialysis room. Like I said, recliners. God. So complications from hemodialysis can be blood pressure, hypotension, like I said, we're going to stand them on our head, muscle cramps, losing blood if the dialysis tech or the dialysis nurse doesn't get the connections done right. So that's a you thing. Hepatitis, sepsis. We talked about disequilibrium syndrome. You remember it in the beginning question?
Mm-hmm.
Do what? Somebody have a question?
I said headache, twitches.
Oh, there you go.
I can't remember.
Patients that are really sick in the ICU may have continuous renal replacement therapy, where they're connected to a machine all day and all night, and it's just continuously filtering their blood, similar to what your kidneys normally do, right?
So they never get to come off of it?
When they get better. But they're sick. These are ICU patients. They're not. They're sick. Because you don't need a dialysis nurse. ICU nurses do this, and it may go on for 30 to 40 days. So hopefully they won't need it that long. And that's what this looks like. CRRT. Kidney transplants can be live or cadaver. The live transplants last longer. usually do not remove the old kidney. Kidney transplants, right? Knew it was coming. Kidney transplants are less expensive than dialysis after the first year.
So you just have like 3 kidneys?
Yeah.
That's crazy.
I really did not know that.
Yeah. Now, if this one was cancerous or something like that, I would say they would take it out.
Okay.
So if it has nothing wrong with it, they'll leave it in.
Well, I mean, it's got stuff wrong with it. It's just
I
not
mean,
working.
obviously it wouldn't work.
Right. It's just non-functional, but it's still got blood flow and that sort
I
of
would
thing.
just think there wouldn't be much room in there, but I've never seen inside the nose.
He said somebody had how many? Who
About
said?
3,
Somebody
at
said.
least 4. Amy, she's in
Oh,
about
Amy,
3
yeah.
or 4.
Oh, somebody don't know.
Yeah.
Oh, Amy.
3 or 4, because I know she's had at least.
Is she one of
she's had
ours?
3 or 4.
No, it's like we know.
All right. So they're ready. They're going to you're going to have to match your blood type and your tissue type to be eligible. You get more points if you're younger than 19. Exceptions to these rules, as far as the waiting list goes, if the patient will die immediately if they don't get it, or if they are a perfect match with blood and tissues, then you're going to get the kidney. That doesn't happen very often.
Now that person loses a kidney. He's donating a kidney.
Yep. Is that the end?
Yeah. That's what it was.
Well,
It's not the end, is it?
no.
Huh?
She's
It's done, give up.
talking to her.
Let's see. How's that work?
Nursing management, of course, is going to pre-op teaching, post-op teaching, which you all know. Teach your patients that they may need dialysis until they get their new kidney. Oh, come on. You've been doing fine all day. No, mine's not cold.
Get it hard. There.
Complications, of course, would be rejection, infection, kidney not working like it's supposed to. Here is your kidney transplant. You see they get kicked out of the patient.
Well, that's it. That's the end.
Not for me.
Did you listen? A little bit.
You do listen.
The client with chronic renal failure returns to the nursing unit following a hemodialysis treatment. On assessment, the nurse notes that the client's temperature is 100.2. Which of the following is the appropriate nursing action?
3.
Why?
Because it's 144 fever.
You just have blood, so it's close.
And the blood's warm. Let me tell you,
Because the blood's warm, that when it comes through the dialysis machine. Thank you.
Well, I mean, they don't have
Was it not 4?
Come on. I don't have.
It's not 4, huh?
to.
Sure it's not 4. It wouldn't be 4?
It's not 4.
Okay.
The nurse is performing an assessment on a client who has returned from. Is that the same one? No.
No.
Patient is complaining of headache and nausea and is extremely restless. Which of the following is the most appropriate nursing diagnosis?
Three. 2 or 3?
3. I'd say 1, but you're already doing that.
I mean, they probably are nauseated, but. Well, it does say nausea. It says medication for nausea. That's gonna make them restless.
What do we think's going on?
They're sick. They need some.
Come on.
They need some Zofran.
Okay, 4.
What do we think's going on?
There's pain.
He's got disequilibrium syndrome.
Oh my God. That's what I was thinking.
Yeah.
Okay.
Come on. That's the third time we've talked about that.
That's gonna be on the test.
There's 50 questions of it on the test.
What's the
In
answer?
16 different ways.
I'm getting a headache.
That one gives the answer.
What?
So what was it?
I don't know because I keep screwing up.
Ooh, I got that one.
Okay, that's where we were.
A client newly diagnosed with renal failure has just been started on peritoneal dialysis. During the infusion of dialysate, the client complains of abdominal pain. Which action is most appropriate?
1, 3,
We'll stop it.
2.
or 2.
2.
Just stop.
I would stop it.
I'd say 3.
Go to McDonald's and get a hamburger. Stop it.
The correct answer is
1.
4.
4.
Teach the patient that the pain will subside after the first few exchanges. It's common for there to be some pain because there's going to be
Okay.
pressure on the abdominal organs. The nurse is instructing a client with diabetes mellitus about peritoneal dialysis. The nurse tells the client that it is important to maintain the prescribed dwell time for the dialysis because of the risk of what?
1. I wanted to say 4, just to, but it's 4. Yeah. 4.
The nurse is instructing.
4. It's 1.
You don't want to leave it in too long because
If it's not low, it's gonna be 4.
What is it?
it's hyperglycemia.
That don't make sense.
Peritoneal fluid.
Diabetes.
The dialysate has lots of sugar in it.
I thought you meant you didn't want it to be swallowed in that long, so you didn't want it to get infected. I would challenge you on that.
We need to
It doesn't increase, having it stay in your stomach too long or your abdominal cavity would not increase the risk
I didn't know
of
that about the
infection.
infusion. It's
Keeping the catheter dirty when you put it in is going to increase your risk for infection.
hyperglycemia.
But if you think about hypertonic fluids full of sugar, isn't it?
Okay. I get it.
All right.
Put that on the test.
A week after kidney transplantation, the client develops a temperature of 101, the blood pressure is elevated, and the kidney is tender. The x-ray indicates that the transplanted kidney is enlarged. Based on these assessment findings, the nurse would suspect which of the following complications?
Yeah.
2.
1.
Yeah, 1.
No, not 2. Not 2.
Maybe.
Acute rejection, yes. What does somebody's kidneys look like that are in chronic renal failure?
Shut down. No.
They're little. They're little. Don't say ain't, but they're not.
Oh, yeah.
The nurse monitoring a client receiving peritoneal dialysis notes that the client's outflow is less than the inflow.
Oh, no.
What nursing action should the nurse take? Select all that apply.
Nice and flu.
3, 4, 5, 2,
Oh, 3.
2,
4, 5. 2, 3, 4, 5.
3. Oh, all apply.
Before we do one.
That's all that apply. 2,
3,
3, 4, 5. Good job. You got one.